Good evening, and thank you for joining us for the first of our five-part series on autism, where we will all gain a better understanding of the spectrum of autism and learn about some practical interventions that parents can use. Today's session focuses on preschool issues in autism, sleep, and behavior. A couple of housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions audibly, please note the QA function on your screen. If you have a question that is not addressed during the presentation, feel free to submit it through the QA feature, and we will address as many as possible before the end of our session today. Also, this webinar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link once it's live. It usually takes about 1 week, so please be patient. We will also have attendee certificates for you as well, and that too will come through with the email. And it is now my pleasure to introduce our presenter for this session. We're fortunate today to hear from a nationally recognized expert on autism. Dr. Max Wisnitzer is a pediatric neurologist at University Hospitals, Rainbow Babies and Children's Hospital, and professor of pediatrics at Case Western Reserve University School of Medicine. Dr. Wisnitzer holds 3 board certifications in pediatrics and in psychiatry, and neurology, with an emphasis in both neurodevelopmental disabilities and special qualifications in child neurology. He has been serving families at Rainbow for 36 years. And now it's my turn to turn it over to Dr. Wisnitzer to kick off this year's series. Dr. Wisnitzer?
Thank you very much, and thank you for everyone for attending today. I'm pleased to give this talk because I recognize that with our families, 2 of the big issues that impact on the children and on their family units are sleep and behavior. So without much ado, I'm going to start us moving forward. First thing we need to understand here before we can actually talk about sleep and the sleep disorders is we have to have an understanding of what sleep actually is and how it's structured. And all sleep really is a decrease in our awareness of what's going on in the environment that is normal, which is what physiologic means. And it's not someone didn't hit you over the head with a 2x4 to knock you out, but this is a normal phenomenon. And the purpose of it has an impact on brain development. We know that there's more sleep in younger children than there are in adults. And also it helps with basically helping restore us in general, and also help us consolidate learning and memory, which means lack of sleep can have a negative impact in multiple spheres. I'll talk about that in a little bit. There are different sleep stages, and that's an important thing to know about. Sleep is not one unit. It's built up of several subunits that are present throughout the night. There's a stage of drowsiness, which I know we all enjoy, and probably someone will be enjoying during my talk. Then we go into light sleep, what's called slow wave or deep sleep. And then we go into dream sleep, which is REM sleep. REM stands for rapid eye movements because the eyes are moving during that time period. And during REM sleep, basically our body mainly turns off connections to the muscles so that we don't act out our dreams. The timing is there's more of the non-REM deep sleep in the early portion of the night and more REM sleep in the later portion of the night. The only time that this is different if you're chronically sleep deprived, you may actually go into REM sleep from the very beginning. When you look at sleep cycles, and this is something that people have to remember, here's basically the different stages of sleep. We go into stage 2, we go into stage 3, we go into the REM or dream sleep, and then the cycle repeats itself. The REM going to stage 2 or stage 3, 4 through a night. But throughout the night, there are also little times here in the orange during which you will go into small little micro arousals. You basically will wake up to surveil your environment, to check out what's going on around you. This probably has a biologic meaning to it. in the times when we were living in dangerous environments, who knew it could happen to you in the middle of the night, you had to be aware of what was happening in case you had to react quickly. Nowadays, when we do these arousals, we basically do a quick check of what's inside of us and also what's going on outside of us. What's inside of us would be simple questions like, how do I feel? Is my bladder full? Do I have to go to the bathroom? What's outside of us would be, did my spouse steal my blankets and I've got to grab them back again? Things of that nature. But the point being, this is the time when we check what's going on around us, and it has an impact on the sleep patterns that we can see in children with autism and other developmental disabilities. Now, we know that over time, depends from the time that you're youngest to the time that you're basically an adult, that sleep changes. The total amount of sleep changes from about 16 hours at night to about 8 hours at night. And as we know with babies and with toddlers, that they nap part of they sleep part of the time at night. Hopefully they will sleep through the night at a reasonable time. And then they will also nap during the daytime. Daytime naps tend to fade by about age 3, 4 years of age, which I find interesting for preschools that still demand that kids at 4 and 5 years of age are supposed to be napping. It does not always work. But this is important to recognize, because if this cycle is not followed, you're going to basically have significant sleep deprivation. What's the effect of not having enough sleep? Very simple. We know this for normal children in the preschool years. Up to 20 to 25% of them will have disturbances in either falling asleep, staying asleep, or certain sleep patterns that occur, which are called parasomnias. But in children with developmental disabilities, those numbers go up. Children with behavior issues such as ADHD, the numbers go up to maybe about 35, 40%. Individuals with intellectual disability, 40%. But in autism, it's thought to be between 60 and 70% of the population will have a problem falling asleep or staying asleep for the most part. Interestingly, problems like sleepwalking, sleep talking, night terrors really are not much different than that population in comparison to the general population. Doesn't mean that these problems don't happen, but the big problems we have in the ASD population is problems falling asleep and staying asleep. That includes also shifting your sleep, because if you fall asleep at a very late hour, then you'll get up at a late hour. So that's called a sleep phase problem. Now, the impact of inadequate sleep hits three areas. It hits cognitive or brain functioning skills, behavioral functioning, as well as your physical status. If you look at the physical status, little babies who do not get enough sleep can actually have failure to thrive. They may not grow right. And obviously, if you don't get enough sleep, you're going to have fatigue, you're going to be tired all the time. It may actually impact negatively on your immune system. From a behavior standpoint, if you don't get enough sleep, you basically can look like you have ADHD with a temper. You'll be emotionally labile, you'll be crabby, you'll be irritable, you'll be very moody, you may not look as happy. Obviously, this not only impacts the individual, but those in the individual's environment. And then lastly, from a cognition standpoint, because you don't pay good attention, you basically may not be able to organize yourself well, manage your time well, and you won't have the ability to learn. One, you're not going to pay attention in the classroom, and number two, you're not consolidating or basically keeping or making permanent the lessons that you learned during the daytime at night, because you're not sleeping at night, a time when you're supposed to consolidate your memories. When we look at problems with sleep, we have problems with sleep initiation, which is sleep onset, sleep maintenance, which is continuing to sleep through the night, sleep phase, as I explained, falling asleep too early or too late, and therefore waking up too early or too late, parasomnias, as I mentioned before, sleepwalking, sleep talking, night terrors, even sleep eating, believe it or not, that can occur. But again, this is not markedly elevated in this population. And you can also have excessive daytime sleepiness due to problems that we typically do not see in the preschool population, except for if you have things like sleep apnea, which is not unique to the ASD population. Sleep apnea is basically disturbances in your breathing patterns and sleep, in which you basically have a lot of respiratory pauses. You have little small times when you stop breathing, and therefore you're not able to cycle through the typical sleep patterns the way you expect, because it's like someone waking you up on a regular basis, just shaking your shoulder and waking you up, there's no way you're going to get a good night's sleep then. So why do sleep problems occur in individuals with autism? Now, this is above and beyond what sleep problems will occur in children who are preschoolers, period. There's lots of reasons, some of them subsumed within the ASD population. So if we look at it for children with problems falling asleep, children with autism, we know, have restricted interest and repetitive or stereotypic behaviors. They may have problems transitioning to bedtime because it's not, there may be some changes in routine, or it changes the daytime routine to the nighttime routine. It doesn't work. They may just have resistance to the change in general. They may expect certain patterns to occur. So if they're supposed to go to bed at 7 o'clock, they want to be in bed at 7 o'clock. You try to put them to bed at 8, and it doesn't work because that was not the time I'm supposed to fall asleep. And even children with ASD can have separation anxiety. That doesn't mean that you can't have that. And I've seen children like this who basically can't separate from their parents. And if you put them in bed, they keep coming out over and over and over again. For children who have problems with communication, because that happens in ASD, they don't understand the sleep rules, the sleep routine, the things that we're supposed to be doing. And in addition to that, besides the separation anxiety, there can be other fears that they have at night, just like other children do. There can be fears of the dark, fear of noises. There can be lights flashing that bother you that can be there. There could be stimulus hypersensitivity, which could be anything from sounds around you to perhaps how the bed sheets feel. They may not be able to calm themselves down, therefore have a high level of arousal. Or if the children also have coexisting ADHD tendencies, they may be able to calm down and they just have to keep moving around. They can't unwind. If we look at children who have problems with sleep maintenance, which means staying asleep, a big reason why children will have problems staying asleep is because they don't fall asleep appropriately. In other words, they don't have an inappropriate sleep association. There's problems with how they associate staying asleep. An example would be if I fall asleep with my mother in the room, and then my mother leaves the room, during one of my time periods of microarousal, when I wake up to survey what's going on around me, and I don't want things to change, I notice my mother's not there. So what do? I wake up and I go look for my mother. If I lose my blanket or my security blanket, whatever, the same thing can happen. Children can also have problems staying asleep if you change their environment. You go to a hotel room. You basically move to a new house. You change. You can even do something as simple as changing the furniture around the room, changing the wallpaper, or putting new poster up on the board. It can do things like that. If children expect that they're supposed to, that if they've gotten into a pattern of falling asleep and waking up at 2 a.m. in the morning, they may get that as a fixed pattern of behavior, as we can see in the ASD population, and they will continue to do that even after you may have taken care of the original reason why they were waking up. I have some patients, some of my higher functioning patients, who are worried about, will I wake up in time? Will my alarm clock wake up? And they wake up all the time to check the clock, things of this nature. Some children will wake up because they're hungry. Perhaps it's a medication effect from the daytime. Either they didn't get enough to eat because maybe there was a medicine that blunted their appetite, or they're on a medicine that increases appetite. They wake up to look for food. And again, other reasons that can disturb your sleep with illnesses. Illnesses can be things like asthma. Illnesses can be things like reflux. Illnesses can be things like, as I mentioned, sleep apnea that can be present. So, and all the other things on this list here can basically contribute to basic difficulties staying asleep. Now, for intervention, number one, if you can identify an underlying condition that is disturbing the sleep pattern, you deal with it. If a child has sleep apnea, treat the sleep apnea. That will basically help the child sleep through the night much better. If a child has asthma, if the child has reflux and we treat those conditions, that will also make them better. If they have an epilepsy and it wakes them up at night, if we can get better control of the epilepsy, I know sometimes you can, sometimes you can't. We can see things that improve. There's also behavioral, and I'll show some of these things on later slides. There's also behavioral approaches, making sure we've got good sleep habits called sleep hygiene, that you have changes in the environment, that parents know what to do. And then there's also medicine choices. So here, if we're looking at identification of triggers, I had mentioned some of the triggers before. It could be a medical problem. It could be nutrition. It could be the child has a psychiatric or medical disorder that's that's present. For instance, if a child has an anxiety disorder, their mind can't turn off. I had a young patient in today who told me, I can't turn my mind off. That's why I can't fall asleep. I worry about tomorrow too much. So if we deal with that, that's good. Depression can interfere with sleep. As I mentioned, ADHD can do it. Allergies can easily do that and make you not sleep well at night. From the environment, I had one young man, I still remember this story, who after a trip to Disney wouldn't fall asleep in his bedroom. It turns out he had a negative experience with Mickey Mouse, the big 7-foot Mickey Mouse. And that freaks little kids out. I used to sit at Disney watching the little kids and the big Disney characters. And it's frightening to little kids when they have a character like that coming in, no matter how much you like that character. And what was his room decorated in? It was all Mickey Mouse. Of course he wouldn't fall asleep. So once he basically had an environment change, all the Mickey Mouse was taken out, he fell asleep perfectly okay. So you have to really check what the environment is like. And as I said, the internal environment of the child, what it's like, as well as conditions that might be present. The behavioral interventions, I'm not here really to tell you how to fix it. There are some good resources. I always recommend the parents Richard Ferber's FERBER book, Solve Your Child's Sleep Problem. It is still the Bible that everyone copies from. It's a good one, whether you have developmental problems or not, in order to understand the problems that children have with sleep and how to address them. But for behavioral interventions, a regular routine, a regular schedule, making sure that children can associate, this is the room where I fall asleep. This is how I fall asleep. This is, maintaining the sleep environment is a constant thing. Maybe making sure a parent isn't in the room when the child is. Now, some children have to sleep with their parents, and that's fine. I understand that. Avoid stimuli. I've had sometimes where parents will do things like put a Dutch door on the outside so that they can lock the bottom and keep the top open so the child feels safe, but the child can't get out. Don't pay attention at nighttime. Make sure the caregiver, the parent, gets out of the room in an appropriate time period while the child's still awake, so the child does not expect the parent to be in there all night. Some children are being put to bed too early. You may find that a later bedtime can help out with that. Other times, if they're falling asleep too late, you may find that if you wake them up in the morning so they're a bit more tired, they'll fall asleep earlier. And obviously, always using a positive reinforcement model that's there. There are medications that can help children fall asleep. There are the one that probably we have the most experience with, and for which the American Academy of Neurology actually wrote a guideline for the ASD population, was the use of melatonin. They recommended, if possible, USP grade, which is pharmaceutical grade melatonin, but the stuff that you buy in the stores is usually very good. Very rarely do we find that what's in the box is not really what's supposed to be in the box. That's not a common occurrence. And the dosing of melatonin can be anywhere between 0.5 to 10 milligrams, depending on what the child's needs are in that regard. And it comes in a variety of formulations. It comes as a liquid, it comes as a pill, it comes as a melt tab, it comes as a chewy. You name it, it's there. It comes mixed with other substances that can also be potentially beneficial. The other thing, but if we have to give prescription medications, probably the one that's used most often is clonidine. It's a medicine originally developed for blood pressure control, but it has a positive effect in terms of fixing. So let's go back. It has a side effect of making you tired and drowsy, and also calming you, and it can help many people fall asleep. I've had adolescents who still need that to fall asleep, and fall asleep quite nicely with it. Diphenhydramine or Benadryl can also be very helpful. The problem with diphenhydramine and some of its cousins is that at times the children may actually get more revved up compared to more calm, depending on what receptor, what parking space in the brain the Benadryl molecule parks. If it parks on a certain molecule, it will literally rev you up. If it parks in another place, it will calm you down and help you go to sleep. And there's a whole bunch of other prescription medications that people use. Probably, if you're going to use something to help people stay asleep, probably the two most common ones that are used are trazodone, which is on this list, which is an antidepressant that has the sedation effects, and mirtazapine or Remeron, which also is an antidepressant with sedation effects, can be very helpful in the population. There are reasonable written reports about this. People have also talked about using other medications that depending on what their conditions are. And I've listed some of them that are here. We can occasionally use what's called a benzodiazepine, a Valium-like drug, if there's extreme anxiety that's present that only needs that kind of medication to calm down. Typical sleeping pills, Ambien, Lunesta, and drugs of that type actually make the kids worse, not better, if you give them at night, based on the fact that there's certain receptors in the brain that really are not mature at that point, and therefore the children may have a different reaction that you would typically expect. Now, in summary, because we just talked about the sleep, in summary, sleep disturbances in the autism population occur in a majority of the population at time, primarily in the preschool years, usually involves problems falling asleep and problems staying asleep. We know that poor sleep can have a negative effect on the child's daytime functioning, as well as a negative effect on the entire family unit. We know from research work that's been done that children with autism spectrum disorder have immature sleep patterns for age. In other words, if you look at their sleep patterns, they many times tend to be those of a younger child, and also that their sleep may not be the autism itself, but maybe some coexisting conditions, whether it's the anxiety disorder that's present, or whether it's the ADHD type behaviors, the hyperactivity behaviors that are present, or problems that can occur in almost any other children in the population. You can have sleep apnea, you can have gastroesophageal reflux, spitting up, you can have asthma that acts up at night, you can have an acute medical condition, you can have an ear infection, you can have a problem with your teeth, you can have problems with constipation and your belly hurts. And if you have a nonverbal child, you're not going to know what's going on. You got to sort all these pieces out. Interventions are available. We stress the behavioral interventions that are available. That's why we have a behavioral sleep clinic here, not just a sleep medicine clinic, but also a behavioral sleep clinic that's present, because the majority of the time it can be fixed with that. But medications are available if they're needed in order to help with the transition to learning the appropriate habit behaviors, or in those children where you really need to do it because otherwise they don't count. So now let's move on to the issue of behaviors in the preschool years. If we look at that now, when we look at problem behaviors in the ASD population, there are quite a few that we can have. The kids can be aggressive, kids can have tantrums, they can get easily upset, they can attack people, or they can hurt themselves, what's called self-injury, bite themselves or bang their heads or whatever it would be. Some of the children are just crabby and irritable and cry easily, and they can be very edgy. We know in the ASD population, children may not tolerate unexpected change. They're very rigid. They want things to always be the same way. If you can't move the furniture around. You can't drive a different way to wherever you typically go. The children can be overactive, and they can also have repetitive actions and thoughts, almost like an OCD type of a picture. Now, if I have a child in the ASD population who's aggressive, again, that behavior does not only impact the child, but also impacts those around the child. It can have a negative impact in the home setting. It can have a negative impact in the community setting. It can have a negative impact in the school setting. So these are issues that we really need to address. One of the things we always have to recognize, similar to sleep, is that children in the preschool years are still working on maturing their ability to control themselves and control their emotions. We all hear about the terrible twos, and there's actually the worst threes, where children are working on self-control and self-regulation. And this is the stuff that they have to work on. Now imagine that I've got, in addition, an ASD diagnosis. Perhaps there's issues with my understanding of what's going on around me. Perhaps there's issues that I just can't tolerate any unexpected changes. It's going to magnify the behaviors that we typically see in the pediatric population at that age. And instead of basically, by the time you get past 3-4 years of age, calming down and being able to really take care of myself by myself in terms of not getting that upset, but because I'm impulsive or because I have all these other issues, I may still react in a negative way. So when we look at this population, what we have to ask ourselves is, when we have disruptive behavior, when we have upsets, when we have behavior problems, what's driving those behaviors? And there's 3 major areas the behaviors can arise from. They can be biologic, it can be innate. We know it can be the ASD or comorbid, a coexisting problem with ASD, ADHD type behaviors or hyperactivity, behavior, things such as anxiety disorders, mood disturbances, which are not common, but occasionally can occur in the population. It could be the illness. It could be the fact that they're having some medication side effect. But what it is the body's biology, the system just isn't working right. But in addition to that, there can be psychosocial influences that can be present. That means how the family reacts to that child, how the parent takes care of that child, and how the child reacts to the family. And then thirdly, there's things that come from outside the environment, and outside the family environment, the community you live in and its impact on you. Well, how you're treated at school, how you're treated at the store, what neighborhood you live in. Can you go outside and play? Are there disruptions? Are there conflicts within the environment that are present? So on each of these things, we need to identify specifically what the trigger is. And once you identify the trigger, you can then do the intervention. Here's another model that I use. When we look at this, when we're looking at disruptive behavior causes, there are behavioral reasons, there's medical reasons, and there's psychiatric reasons. Going through a list of some of these issues, especially in the ASD population, there can be problems getting your message across. If you're a nonverbal child who's impulsive and you're 3 years old and people do not understand what you want, you may react before you think, which means you may have tantrums, you may hit. It's stuff that we have to watch. Secondly, if you've got a 9-year-old child with ASD, but mentally they're at a 3-year-old level, they may have the behavioral aspects of the 3-year-old population. So you have got to consider where they are developmentally. Sometimes you'll have disruptive behaviors because the children have learned, if I do this, it either gets me out of something I don't want to do, or it gets attention drawn to me, and that's what I want. I want people to pay attention for something I want. Even the ASD population may want something. Maybe they're hungry, or they want some toy that they're after, something that's there. There may be resistance to change, as we discussed before. There may be a lack of understanding of what's going on, or lack of interest of what's going on, and they just get bored, and to some degree they may react in this manner. And also there could be other things in the environment that push you over the edge. For an example would be a child with ASD who's being teased by classmates. And after a while, the child may not tolerate that teasing anymore, or being bullied by classmates. They may not tolerate the bullying anymore. And you're going to get a behavioral outburst that unfortunately gets that child into trouble unless people say, why did the behavior occur? Why was it there? There can be psychiatric reasons. Children with ADHD are impulsive. Impulsive children can be aggressive because, again, as I stated before, they react before they think. Children can have opposition-defiant behaviors in which their favorite word is no. I'm not going to do it. No. In the preschool years, opposition-defiant behaviors many times are linked to ADHD, or they're linked to anxiety disorders, or they're linked to learned behavior patterns that are there. Think of some of the characters in the Willy Wonka movies. I think it's Violetta. Daddy, I want this, I want this, I want this. And no, she nags and nags and nags, and she's disruptive because of that. You can have children later on who can have conduct disorders, which is basically violations of societal rules, whether it's deliberate or inadvertent, but it can lead to disruptions. If you're very anxious, if you're very stressed, you can either shut down and stay within yourself, or if you have an impulsive and you can't take it, you may react by aggressive behaviors that are there. And same thing can happen with people with obsessive compulsive behaviors that happen. In fact, if you look at the OCD population, and about 50% of them can be disruptive, especially if they're symptomatic in the preschool years, simply because of this impulsive nature that's there. Kids with mood disorders can behave this way just because of their mood. And obviously we don't see psychosis in the preschool years, but in the older population, if there is a psychotic or a thought disorder, that can lead to aggressive behaviors because they may misinterpret how the environment is or what's going on in the environment. But when you look at medical reasons, children who have seizures and are post-ictal, which means after a seizure, they're not totally there, they're drowsy, they're tired, they're a bit confused. If you try to interact with them, there may be some reactive aggression where they're pushing or pulling simply because they don't know what's happening in the environment and it's bothering them. Lack of sleep, as we talked about before, can lead to this. In the higher functioning individuals, not in the preschool years, but in the later years, you can have substance use, using illegal drugs as a reason that might lead to this. Traumatic brain injury can do this if the children with an ASD in addition have a brain injury that's present. Sensory impairments, if you don't hear well, if you don't see well, in addition to having ASD, that's a further impediment or barrier to really performing adequately, and you can get into trouble because of this. And again, any other medical or dental condition, anything acute medical that can bother you, usually you may not see it. So you've got to look in the ears, you've got to look in the throat, you've got to look in the nose. You basically have to check out the belly. Is it something they're eating? Is it the fact that they're chronically constipated? Did they hurt something? Do they have a splinter? Is one of the teeth not right? Do they have periodontal disease? There's lots of reasons why this may happen, and sometimes we just don't know. Luckily, as time has gone on, the not knowing category has gotten smaller and smaller and smaller. Now, in autism populations specifically, if we're looking for some of the psychiatric or medical problems, ADHD, anxiety disorder, obsessive compulsive behaviors, mood disturbances, seizures, tics, sleep disturbance can all be contributing factors that are there. So if we look at ADHD individuals, they have short attention spans. But the question you have to ask yourself is, when they have attentional problems, is the short attention span actually related to ADHD, or could it be to other reasons? So yes, you can have a short attention span because of ADHD, but you can also have a short attention span because you're very anxious and nervous and hyper aroused and hyper aware of everything around you. So basically, you just don't have time to pay attention to what you should be learning or doing because other things are catching you there. If your mood is down, if you're irritable, or in the rare cases where you have individuals whose moods are too high, they're manic or hypomanic, again, you have a short attention span. There are some people who just have social withdrawal that's present, that they may not want to interact with those around them, or they may not understand what's going on around them, or have no interest. If you're bored out of your mind, you're not going to pay attention to anything that's going on around you. That holds for children as well as adults. For ADHD, it's a short attention span for mental age, which in other words, if I'm 10 years old and I have the intelligence of a 10-year-old, I should have the attention span of a 10-year-old. If I'm 10 years old, but I have the intelligence of a 5-year-old, I should have the attention span of a 5-year-old. It's always something to consider, because if I've got a 3 or 4-year-old child who cognitively is more at a 1-year-old level, their attention span is going to be that of a 1-year-old. And their behaviors are going to be that more of a 1-year-old than it is of a 3 or 4-year-old. In addition to this, with ADHD, the children are overactive. That means anything from being fidgety to literally bouncing off the walls, running into the street without looking for cars, running in stores and disappearing, going out the door so that you have to put locks on the doors and everything else like this. They react before they think, so they can be impulsive. The ones who are verbal also will say things without thinking of the consequences of what they're being of what's being said. They're easily distractible. The behavior occurs in 2 or more environments, not just one, but in multiple settings, whether you're in the store, whether you're at home, whether you're at school, whether in the older population, whether you're at work. And it doesn't even matter to some degree who you're with. It has to be present for at least 6 months. In other words, it's not due to some acute medical problem. It interferes with your day-to-day functioning. And it used to be that the onset was prior to age 7 years. It's now prior to age 12 years, but they're symptomatic long before that, if you really know the questions to be asked. Anxiety, on the other hand, is I like this definition. It's apprehensive in anticipation of future danger or misfortune out of proportion to the perceived threat. What this means is you're worrying about something that's going to be coming on out of proportion to what it really is. You're making a true mountain out of a molehill. It would be like I was at the drugstore the other day waiting for a prescription, and there was a young man getting his COVID booster shot. And for those of you who've gotten the shot, for the most part, it doesn't really hurt. But there was high drama, lots of screaming, lots of agitation, lots of complaining until the shot was given. And then he calmed down when he figured out it wasn't going to be as bad as I thought. The danger could be internal or it can be external, which means you may perceive it within yourself as something that's going on. You feel very antsy, or you think that the anticipated danger is something from the outside. There's a storm that's kind of coming. The storm, by the way, is in Kansas and we're in Cleveland, but I'm worried that it may get here. Forest fires in California may hit here. My mother, where is she? I don't know what's going on. Oh my gosh, maybe she got hit by a car. Things of this nature. And by the way, I'm saying these words even if the kids can't verbalize. There can be physical features present in the young child. They can be sweaty. They can turn pale. Their heart bases. Their palms are moist. In older individuals, they may complain of headache. They may complain of stomach ache. Those who can speak, their faces, their ears turn bright red. Those are things to watch. And if we tell them to relax, it doesn't work. They can't shut it down. The anxiety controls them. They don't control the anxiety. And when we look at anxiety, especially in the young children, there's separation anxiety, which means I can't be without my primary caregiver, whoever it would be. You can be fearful of everything in your environment, the generalized anxiety disorder. You can have a fear of interacting with other people for fear maybe you'll say something wrong, you're going to be criticized, which may be one reason these children don't talk in the school setting, won't talk to their teachers. I had a young man in today, that's exactly what was going on with him. Above and beyond his ASD diagnosis, he could talk, but he wouldn't because he just was too stressed by the social interaction that was there, that was being forced on him. There are specific fears as well as obsessive compulsive behaviors. Obsession is an inappropriate thought or idea that comes into your mind and you can't get it out. And a compulsion is the action you do to reduce that thought. Now, an example nowadays would be COVID. Your fear is COVID's everywhere. So I touch a surface, I've got to go wash my hands or clean it with sanitizer. And I do it over and over and over again throughout the day. Tics are basically sudden, rapid, recurrent, non-rhythmic movements or noises or sounds that you make. So you can have a tic that's a shoulder shrug. You can have a tic that's a grimace. You can have a tic that's a quick head movement. You can have throat clearing, sniffing, snorting, arm and leg movements. There's a whole bunch of different tics. There's a whole repertoire of tics. So they can be motor tics or vocal or phonic tics. They can be simple like I just did or be a whole complex action that you do. If they're there for just a short period of time, a few months, a few weeks or a few months, don't come back. Those are known as transient tics. If they're present for more than 12 months, it's considered to be a chronic tic disorder, whether it's chronic motor tics or chronic vocal tics. If you have both together, by definition, that's Tourette's syndrome. Tic disorders can be associated with mood disturbances. About 10% of the individuals will have problems controlling their mood. They're overreactive. They're more temperamental than usual. It also is associated with anxiety and obsessive compulsive behaviors. Those are things that we have to watch for the most part. Lastly, kids in the ASD population can have self-injurious behaviors. Self-injurious behaviors are driven by problems with communication. In other words, I can't get my message across. I don't know how to really get it to you. I get very frustrated. I hit myself. And then the hitting itself turns into a message of I'm upset. So I use my hitting myself to communicate my upset or of something so you understand what I'm doing because I can't say it any other way. Self-injurious behaviors can also be done because children want to avoid a situation they perceive as either too stressful or something they just don't want to do. So I have children who hit themselves every time they may be walking into a place where they feel stressed or upset because they don't want to be there. It can be attention seeking. You're not looking at me, you're not paying attention to me. So I'm going to start biting myself. I'm going to start hitting myself. And then when people react, the kids say, aha, I get a reaction here. They don't say those words actually, but this is almost the thinking process, and it consolidates the behavior in such a way that this is exactly what it turns into a habit. All these three things, whether it's communication, avoidance, or attention seeking, it turns into a habit behavior. This is what the kids do. They do this, and this is their automatic reaction and response, and it's something that can be broken. Lastly, self-injurious behavior can be compulsive in nature. There can be behaviors of this type where you bite yourself almost like in an obsessive compulsive type of a manner. Obviously, there the intervention would be different than the top 3 that are there, but it's something that has to be recognized. Now, for all these, I'm not really here to talk about the treatment of these, but the treatment is very simple if we think about it. When you're looking at disruptive behaviors, the first thing we have to do is ask ourselves why they're there. So when we ask ourselves why they're there, you do what's called a functional analysis of behaviors. You go in and say, what's the behavior? What preceded the behavior that I perceive as the potential trigger? And what is the consequence or impact of the behavior? In other words, what's the gain for the child in that setting, whether it's a positive gain or a negative gain. But if it's the only habit the child has, that this is how I'm going to react, then the child will continue and persist in that behavior pattern. Once you've done your functional analysis of behavior, you can then say to yourself, is this related to an underlying medical or psychiatric problem? Is it related to some behavioral or communication disorder? Is it something that's been going on for a long time? Is it something that's there for a short time where we never saw it before? At which point I look for physical reasons that are there, and then you intervene appropriately for what those are. If it's behavioral, you have to really get a program in place where if the child is using the behavior for communication purposes, for instance, Johnny doesn't have a lot of words. And because of this, when Johnny gets frustrated or upset, Johnny hits you instead of saying no. We need to teach Johnny how to communicate, even if no words, using a nonverbal communication strategy as an example. Whether it's a picture-based system, whether it's a computer-based system with some sort of software that's installed on it, whether we teach them some sort of gesturing or pointing, whatever it would be. But we go after these skills, and what we do is we substitute the wanted behavior and respond to it appropriately. Doesn't mean we give in. I'll talk about that in a minute. Doesn't mean we give in to these children, but we substitute for it. And when we substitute this as an appropriate behavior, the unwanted behavior, which no longer is providing this child with any positive feedback in such a way that it's needed, will slowly fade out of the way. That's assuming that it's all behavioral. If there are medication responsive conditions that also need to be treated, for instance, if anxiety is one of the reasons that's driving this behavior, and the anxiety is controlling the child, so no matter what behavioral intervention I do, it doesn't stop it, you have to medically treat and reduce that anxiety to the point that the child can learn how to control it and learn those good habits. And then perhaps at a later time, we can consider fading whatever medical treatment that was there. But that's the important thing when we look at these. You always have to ask yourself, why? Is it something that's a biologic reason? It's a medical problem. When I'm in medical, that includes psychiatric. Is it a medical condition? Is it something that arises because of my interaction with my immediate environment? Or is it something that arises because of things that are happening from my more global environment, my community, or from my peers, whether they're having a positive or negative impact on me? Those are always the questions we have to ask ourselves. Now, when I talk to parents, I always tell them that there's certain rules that we expect the ASD population to follow. Rule number 1, if you're seeing a behavior that's present, for instance, a child looks very fearful every time there's a thunderstorm outside. The child goes running from bugs. The child is afraid of the dark. The child clings to parents all the time and needs something is basically to try to calm them down. It's an anxiety disorder. In other words, if it looks like a duck, it quacks like a duck, and walks like a duck, it is a duck. You don't have to look for esoteric reasons why that behavior is going on. So remember, the common things still will occur commonly in this population, as long as we understand what is the ASD, what is the autism, and what is some of the comorbid conditions. Number 2, and I keep saying this to people who come to me, they come to me with their children and said, we wonder whether our child has autism because our child has the following X, Y, and Z behaviors. Well, it turns out the X, Y, and Z behaviors, maybe it's a generalized anxiety disorder or ADHD are probably the 2 most common reasons I see them, or social anxiety. So the label that do you have ASD or not is not as important as the intervention to deal with the behavioral issue that is present at that time. After you fix the behavioral issue, if you reduce the anxiety, if you've improved the ADHD, you can then say to yourself, is ASD really present? Or was all the behavior, or were all the behaviors that were going on mimicking an ASD type picture? And now we understand exactly what's happening. Number three, don't do what's best for you, do what's best for your child. Too many some parents will come in with expectations that I want, but that might not be what's best for the child. And they're told by many professionals, this would work for your child, this would work for your child. But for reasons that the parents have, there's lots of reasons, it may not be there. We have to be mature enough to say, it's always what's best for our child, not necessarily what I think that would work and would make me better. So I have parents saying, you got to stop him from screaming, it's driving me crazy. Well, it's important in that situation, but the other thing the parent might need to do is learn how to cope or whatever would be and deal with some of these things, because we may decrease the screaming by 90%, which would be very good. And if the parent says, no, that's not good enough, what's going on here and what's happening in this circumstance? The very important rule of mine is medicine is not a substitute for appropriate parenting and educational programming. Medicine does not teach a child how to learn. Medicine does not teach a child how to behave. Appropriate parenting and behavioral programming can do it. Medication in the appropriate setting can make it easier for the child to achieve the goals, but we don't necessarily expect medicine to fix everything. One of the things that we also remember is parents will come in and say, my child with autism is having tantrums, they're due to his autism. Now, the child never had tantrums before. So the question is, what's going on? These children can have medical conditions just like any other children on the street, any other child in the community. So you've got to look for common reasons. Is there an earache that's going on? Does the child have a sore throat? Does the child have chronic constipation, which is quite common in this population, but also in other children, and can do that. So they're allowed to have the typical medical conditions. It's not necessarily that everything has to be autism centric. One of the things we also have to do is when testing is done, if the test result doesn't fit with what's going on with the child, we might be very careful. Make sure you treat the child and not what the test shows in that regard. So testing may suggest that the child perhaps has a mild attentional issue, but in the real world, in school, at home and everything, we don't see that going on. In that circumstance, we would say, let's leave it alone. On the other hand, testing may suggest the child maybe not have anxiety, perhaps because the child is too scared to show what the anxiety is all about and not sharing all the information. But in other settings, we're getting other information. So we have to look at the whole picture, not just what the test results show. I believe all little children are terrorists. Important rule is never negotiate with terrorists. It does not mean we don't love them. It does not mean we don't want the best for them. But if we give in to everything they do and don't help them learn self-control and self-regulation, there's trouble that's going to be following in years to come. Every child has his price, his or her price. Now, what I mean by this in a positive way is there's always a way of encouraging a child to do the behavior we want to get done. We just have to find out what that important tool is for that encouragement. What's in it for the child to cooperate? I had one little boy that in school he was acting out. The school figured out that that a reward of vanilla Coke, believe it or not, just a vanilla Coke. The child liked to drink vanilla Coke. And if he knew he was going to have a vanilla Coke at the end of the school day, his behavior was 100% better. During the school day, he followed the rules. And because of that, he was able to develop good patterns of behavior that were there. Now, you don't have to always do vanilla Coke. It could be something as simple as a little reward. Don't start with a bicycle or a trip to Cancun, because where do you go from there? Behavior is frequently due to childhood, not autism. In other words, if the child is acting out, ask yourself, is this something I would expect a child of this age, or especially of this mental age, to do that kind of behavior? So it is not unusual for a child to have the terrible twos. If it's not in excess, we blame it on the terrible twos. If we have a child who's 1 year old and crying because something hurts, that's not surprising. That's just a child behavior. And then lastly, we have to remember that these are not autisms. They're not autism spectrum disorders. They're children with this diagnosis. That's only a small part of them. We have to look at the whole child, everything that's going on with them, their areas of strength, their areas of weakness, which everyone has, and we treat them as such. If we treat them as a disease or a disorder, they're going to react as a disease and a disorder. If we treat them as a child, they're going to react positively as a child. I'm going to stop at this point, and Tia, if you want to just basically address what you want to ask the people.
Sure. Thank you, Dr. Wisnitzer. Some really great information. And now I'd like to share with all our attendees that we will open it up to questions. And we do have a few questions in that have been received. One is, does a later bedtime affect the quality of sleep? Like if a child gets his 9 hours of sleep, and this is for a toddler, is it okay if that 9 hours starts at 11 o'clock? What would you say to that?
The time when the child falls asleep may be based in part what the family unit needs or wants. And let me give you an example. I've got children a little bit older that won't fall asleep until their parent comes home from second shift. So for them, they're used to falling asleep at 10 o'clock every night, but if they get a good night's sleep, then that's okay. Obviously, when they're going to be starting a school program and they're going to have to get up a little bit of an earlier hour, you're going to have to shift the sleep, but they're going to shift it themselves because school tires children out. So as long as it works for the family unit, and as long as they're getting a good night's sleep and we see the effects of a good night's sleep, I mean, I wouldn't have the child go to sleep at 3 a.m. in the morning, but a later bedtime may work for some family units as the question was asked.
Okay, super. And then we have another parent who says that she has a 5-year-old with mild ASD, and he is really troubled by monsters, and they have tried to address it many ways, and even to the point of kind of physically shooing the monster, kicking the monster, and clearing the room of pretend monsters. Is that a good approach? What would you say to that?
There are some very creative and innovative ways to do this. As you pointed out, sometimes people will surveil. One of the things that worked quite well for some of the kids that I knew of was to set up a monster trap. So any monster who came in to the room would be caught by the monster trap. And of course, the monster trap had to be invisible so the monster wouldn't see it. And children at that age actually buy that information quite well. Then, of course, you don't want to be mean to the monster. So you take the monster trap every morning and let the monster out the door so that nothing bad happens to the monster. But it's having a creative approach like that. As I said, Dr. Ferber in his book addresses issues of this type. But just ask yourself, what will it be that will help the child calm? I wouldn't necessarily kick the monsters because then the monsters might kick you back. We want to be human. We want to be humane with the monsters. But yes, you can do it. Just think about it. What would work best for the child in terms of addressing this issue?
Great. Another question, are there some resources or a book to find out more about self-regulation techniques that a parent could use?
I don't have off the top of my head. If you're talking about for preschool children, for self-control and self-regulation, I think there are. I just don't know off the top of my head. I'll tell you what you can do, Tia. If you get the name, I'm sure we can get the book sent to them. I mean, you can ask Dr. Berry. If Dr. Berry has an idea about a good book for that.
Yes, okay. You know what? We will address that next session.
Oh, okay. There we go.
Okay, so and I should tell the listeners on the phone that if you signed up for this session, then you have seen that there are 4 more to follow. So the next session with Dr. Berry and Kathleen Maxwell will be a month from now, approximately, and we encourage you to attend again. All right. Why does autism and ADHD have similar symptoms? My daughter that is 2 years old has autism, and my son, who is 10, has ADHD. But my son has done 2 autism evaluations they just keep saying he is severe ADHD, but I get confused on why, I guess what she's saying is the diagnosis is different in the two kids.
These are different diagnoses. In my mind, they look different and they act different. Now, some kids will have both together. But if you look at autism spectrum disorder, that's a disorder predominantly of socialization. And unlike the kids with ADHD, children with ADHD socially don't do what they know. They can be socially immature, but they don't do what they know. Kids with an autism spectrum disorder don't know what to do. There's a difference there. That's a fundamental difference in some of that. For instance, kids with ADHD don't pay attention to social cues because they're attention disorder. Children with autism spectrum disorder don't pay attention to social cues because they don't understand what the significance is. So while superficially you may see things, underneath the underlying reasons why these behaviors occur are really different. But it's an autism spectrum disorder as a disorder of socialization and social communication. And what you've done is you've deviated from the normal path of your peers, but you also have restricted interest and repetitive behaviors that are present. ADHD really, except for the fact that these kids can be socially immature, usually about 2/3 of their calendar age. Their problem is that they have problems paying attention, staying focused, sitting quietly, and controlling their impulsivity, which really does not look like ASD in any manner. So just to answer, they are different creatures. Some people try to claim that they're on a spectrum, but really that's not true. These are different diagnoses. It's just that they can merge when, for instance, ADHD and autism are present in the same person.
Okay, and I know that you addressed this in your slides, and I will remind our listeners, our attendees, that when you get the recorded session, you will see a copy of the slides. But this question is requesting strategies for a child that occasionally wakes up in the middle of the night and won't go back to sleep for a while.
Richard Ferber's book, Solve Your Child's Sleep Problem.
Okay, thank you.
Now, the reason I'm saying that is there's lots of reasons why the kids wake up. Dr. Ferber's book will guide you to try to figure out why that's happening.
Perfect, thank you. And we have time for just a couple more here. How can I calm my child who's waking himself with rocking and humming behaviors?
Well, if you're rocking and humming, you're not waking yourself. That means you're not asleep. If you understand what I mean by that. And little children can a rocking behavior as you want to fall asleep is not uncommon. It's one of these movements that we see, and humming is also not uncommon. So the point is you have to ask yourself, is it going to excess or not? And if they're doing that, why are they doing it? And what can we do about it? In those cases, that would be something that would be good to perhaps consult with our behavioral sleep people.
All right, and this will be our last question. How can I improve my 8-year-old with autism and ADHD and mental retardation, attention, and reduce staring off and assist in self-regulation?
Well, the self-regulation, I think Dr. Berry will address next time. But the issue you have to ask yourself, first question you have to ask yourself is, at what age level is my child functioning? And then when you ask yourself about what age level is my child functioning, is what's the typical attention span for a child of that age? And that's your starting point. So if I've got a 7-year-old, but intellectually they're at a 4-year-old level, you may have an attention span that's about 10 minutes in duration, and that's about it. Secondly, you have to ask, why aren't they paying attention? Is it because they've got ADHD or because they may not be interested? So that requires a whole slew of different questions that are there. So again, to help your child, first figure out what's driving the behavior.
All right, perfect. Well, that concludes our questions. I will just close and say thank you very much to Dr. Wismitzer for your time in sharing this valuable information and answering these questions. And thank you also to our audience for your attention. A couple of reminders for you though. We will email you a link for you to view this session once the recording is posted. That's going to take about a week, so please be patient. We also will have a certificate of attendance that you can access from the email. Many people are interested in that. And then if you would like more information on the Rainbow Autism Center, you can visit our website at uhrainbow.org/autism. And to schedule an appointment with the Rainbow Babies and Children's expert, you can call 216-998-1230. And also, because so much is in the news right now about COVID-19 and children, visit our website at uhrainbow.org/COVID for some really valuable information about the vaccines available and other information that you're seeking. This concludes today's session, and I will thank you again for attending. Join us again in February for our next session in the series.